Okay, so good morning, everybody. Thank you for joining again our Monty Hart Cath conference. As is, we've always tried to get some interesting speakers, and today we have someone extremely interesting, and Professor Carlo Di Mario from Firenze. It's a beautiful picture of Firenze. Professor Di Mario is really world-renowned in the field of intervention TOs, and also does structural heart. I know Carlo for many, many years now. We have a long history. We both at different, I think, eras trained in the same institutions. And I joined in Milano after you had left, Carlo. So I was always disappointed we never got the chance to work together in the cath lab. But then you went on to London and were very successful there, and then came back to Firenze, where you're leading the division there, and continues to do phenomenal work and research and to be involved in this at a global level. So I don't know if everybody knows, but some of the very first cases of lithotripsy done in the world were done by Carlo. He was involved in the very initial early feasibility study, first in human study. Probably, I'm not sure if he did the first ever case or within the first 1 or 2 cases. And so really has seen this technology from its birth to where it is now an important product on our shelves. So Carlo, it's all yours. Thank you again. We're really honored for you that you would spend an hour of your time with us.
Thank you, Azim, Juan, Kathy. Thank you for hosting this lecture on a topic that is very dear to my heart. Yeah, I was also sorry that when you arrived from London, I left for London. But anyway, we cross our paths for some time in Italy, and hopefully this will continue in the future. So, first of all, this is not the newest topic in the world, because that presence of calcium in the coronary tree is related to symptoms of angina was known for a few centuries. I'm sure if you search a bit more carefully, you can go as far back as Hippocrates, or Morgagni, but here are observations of the 18th century from these two English and Scottish physicians that demonstrated the presence of calcium in arteries with people with syncope anginosa, the way they call it, angina. The factors that cause calcification within a plaque are somewhat different from the classical risk factors for atherosclerosis. I will not go through all of it. This is not the topic of my presentation, but I think it's important to understand that there are wide individual differences, and that some individuals may have large plaque volume that are soft, others tend to calcify more earlier. Obviously, everything starts from minuscule, microscopically visible pieces of calcium that then form fragmented calcifications, and then they fuse together to form sheaths of calcium. The most difficult, of course, will be subintimal, preventing expansion of stents. You see, these all are histological arteries with stents poorly expanded inside, and sheaths with the continuous motion of the artery may break and form what we call a calcified nodule, so expand in the vessel, possibly causing also ischemic acute syndrome. 5% of ST elevation myocardial infarction is caused by rupture of calcified nodule rather than soft plaque, which is the paradigm of acute coronary syndrome. This happens mainly at hinge point, typically mid-right coronary artery, even more frequently, but fortunately a bit less diffuse in the general population, vein grafts. Sorry, I think I made a small mistake, but here I am. As you know, the issue is not
Carlo,
limited.
we don't see your slides. Could you just share again, please?
Okay, sorry. I think I, for some reason, left. Let's share again. And then let's go full screen. So just to say that the reason why we see more and more calcium is the fact that our population has changed compared with the 70s or 80s when balloon angioplasty started. We tend to treat elderly patients more often with diabetes mellitus, 30–40% of our patients, also in Europe nowadays. Chronic renal disease is a risk factor for calcification, especially dialysis. Smoking is also a risk factor, and we will limit this presentation to coronary treatment, many procedures worldwide, where calcium moderate to severe is present in 30% of cases, but there are districts in our body, for instance, the femoral-popliteal arteries, similar size to the coronaries, where heavy calcium is even more frequent, more than 50%, since this is a pathology which is more prevalent in diabetic patients. The reason why we have to pay attention to presence of calcium is the fact that the modality of treatment we have do not seem to be very efficient. Out of these 32,000 patients from 21 randomized trials with the first generation and second generation drug-eluting stents recently published, 60% had full follow-up with an average of more than 3 years, and you see that 31.3 out of them had moderate to severe coronary calcification, equally divided into first and second generation drug-eluting stent. They tend to be more often of elderly age, to have a greater burden of baseline comorbidities, diabetes, hyperlipidemia, previous CABG, multivessel disease. And with this follow-up, you see that they tend to have a worse outcome. You have 4 lines. The one at the bottom indicate second generation drug-eluting stent. Overall, they do better than first generation, but the difference of around 5% between yellow and red line and between green and blue line is the difference between absence of mild calcification versus moderate or severe calcium. The best way of assessing presence of calcium is obviously not angiography, which is a very poor sensitivity for assessment of calcium, but are intracoronary imaging techniques, intravascular ultrasound and OCT. As you know, OCT is able to measure the thickness of the calcified plate, and for this reason, a calcium score developed based on OCT is what we normally use as a gold standard for the assessment of those lesions that are considered not responding to conventional treatment, and then at risk, like in the previous slides, to have higher percentages of MACEs at the 4 years follow-up in that particular trial, and you have seen the percentages, they reached around 20%. So they had in New York, Means and colleagues, a test cohort of 128 patients, and these data derived from this cohort, the score derived was applied to an additional 133 patients, not an enormous series then, that's important to remember. Please note that absence of a thick calcium greater than 0.5 millimeter was associated with full stent expansion, or at least greater than 70%. You may wonder whether this is a percentage is sufficiently good, especially in small arteries, to reduce significantly restenosis and thrombosis. However, all cases expanded whether they were thin plates of calcium. Similarly, whether they were short segments of calcium less than 5 millimeter, expansion more than 70% was complete. The angle of calcium, what everybody remembers and mentions, on the contrary, has a bit of a mixed result. Of course, having a greater than 180 degree of calcium was associated with more than around 1/3 of cases of incomplete expansion. But also eccentric calcification did not achieve complete greater than 70% expansion in around 10% of cases. So this is what we normally use, the St. Francis score. We normally consider 4 as a cutoff. So we wanted to have 2 points for more than 180 degree of arc of calcium plus length and thickness. Maybe we should consider whether 3, whether an angle in between 90 and 180 should also be considered. Intravascular ultrasound doesn't measure thickness, but Akiko Mehara, based on her large database, consider these scores points to be significant from a large number of cases, but a retrospective analysis. So greater than 270 degree arc of calcium for more than 5 millimeter gave 1 point, an additional point for 360 degree of calcium, presence of a calcified nodule, and having a smaller vessel, smaller than 3.5, was also considered one factor to be considered for the calcification of measurement of calcium score and the decision making whether you need or not dedicated device for treatment of calcium, since if you have a large enough vessel, you will anyway achieve an absolute lumen sufficiently good to prevent phenomena such as stenosis and thrombosis. These are the results in the groups with and without various levels of calcium score with or without atherectomy. And you see that if you have a calcium score measured with these score points of 4, atherectomy achieves on average less than 70% expansion, absence of atherectomy. But also atherectomy is not perfect and reaches slightly above 80%. So this is a bit of a preparation to what are the techniques that we normally consider for treatment of calcification. In the vast majority of cases, we don't go beyond balloon-based technology, high-pressure balloon, or something recently released in the United States, what I call super high-pressure balloon, the OPM balloon from Sys Medical, a Swiss company, an engineer who was working with Grunzig a long time ago, so knows his job, and managed to manufacture balloon that can go to 40 atmospheres. In fact, there was in the past an indeflator able to go up to 55 atmospheres. Very rarely we observe rupture with this balloon. Cutting balloon, so you drive all your force of your balloon into 3 specific lines, or scoring balloon. And in theory, you can consider a sort of specialty calcium-related balloon, also the intravascular lithotripsy balloon. Atherectomy technique, rotational orbiter, or laser. I confess, I don't think these slides make much sense, because laser atherectomy is not known to ablate calcium. It may modify the proximal end of the calcified segment and allow a balloon to sneak into calcium, but definitely is not a true atherectomy technique. So I would personally go into a technology helpful to treat calcium, while in my view, lithotripsy is truly a calcium dedicated technology, at least on the same level of rotational and orbital atherectomy. I've been a user of this high pressure, super high pressure balloon for a long time, up to 40 atmospheres as a standard. If you use it based on intravascular imaging, knowing the size of the vessel, you may get no perforation. You increase the expansion compared with the result after the 24, 26 atmospheres of a non-compliant balloon. The MLD goes up from 1.7 to 2.4, highly significant, but still expansion is not perfect. Diameter stenosis residual is 20%. Rotational atherectomy, of course, is a more complex technology. Now we do have a system, the RotaPro, which makes the procedure somewhat simpler. The wire is still there, not easy to be inserted, but you normally exchange over a microcatheter. But you can do a single-ended procedure. And as you can see from this comparison between the old rotablator and the new RotaPro, also the percentages of events MACE are similar, but you tend to use less contrast volume and to have a quicker procedure with this new device. If you use, like modernly, you tend to use smaller bursts, 125, 1.5, 175, difficult to call this a truly ablative technique, to have large volumes of tissue. What you do is a bit more what you do with lithotripsy. You create cuts in the calcified plate, and at that level, the balloon works better to open it up. Let me show you an example. A gentleman with a reasonably good mammary, also there is diffuse disease distal, and a vein graft that has been open for 25 years to this obtuse marginal branch, as well as to this distal right coronary, dominant right coronary artery, which is proximally occluded. So the issue and the new development of pain in this elderly but quite active gentleman, who has also some contraindication for prolonged double antiplatelet treatment because of this liver disease, is this highly calcified lesion, probably somewhat present almost 30 years ago, but now much more severe and with dense calcium angiographically. No ultrasound could go through. And you see what happens with the balloon, the heavy indentation that you achieve with a trio non-compliant balloon. In fact, we went to high pressure, and this piece of the balloon was cut from the remaining part. We managed to get inside the guiding catheter. We had to withdraw everything out. At this point, you are left with the same image that you had at the very start, and you need to use different technology. We did try, and we managed, in fact, to go with a trio balloon, but at this point we had an initial rupture after the first series of cuts. So we decided to prepare the lesion with rotational atherectomy. 125 was very difficult to go through. We didn't have a good expansion of a non-compliant balloon, so we went again with lithotripsy, and we had another instance of balloon rupture, but eventually with first a 2.5 and then a 3.5 lithotripsy balloon, we achieved good expansion of the balloon and good expansion, an expansion good enough to insert a short stent and to complete the work on the left main with a very large balloon, with the result that you can see here. So orbital atherectomy potentially can have a greater ablative action on plaques. Of course, in the United States, you have much more experience than in Europe. Still, we miss results from large randomized trial with this technology. Our message in Europe, however, is that rotational or orbital atherectomy are used so rarely in daily practice that they are just covering a small fraction of the cases of severe calcification that are in need of a calcium modifying device. And personally, I don't think cutting balloons are really devices that in extremely calcified lesion are equally effective. So there is still this large unmet need, which can be covered by a technology easier to use, such as lithotripsy, which has been with us for decades, applied externally, but when applied at the site where the calcium is, can use much lower acoustic pressure with much less risk of damage of the vessel, since of the tissues inside the body, since it doesn't go beyond 3 to 7 millimeters around the source of the shock waves. And you know how it works with 10 pulses delivered when the balloon is inflated at low pressure, just enough to have it against the wall of the vessel, sufficiently large to be covering and touching the wall of the vessel, creating steam bubbles that expanding and collapses induce these big shocks that with the high velocity hit the vessel wall, and as you can see, can break a very thick ceramic circle around this lithotripsy peripheral catheter. Of course, you can see very easily the cracks in this eggshell. You can often see them with OCT as well, but we also learned that there are microfractures. These are peripheral arteries studied with micro-CT that are present and explain why you can expand arteries even if you don't see visible cracks. These are the peripheral catheters. The coronary catheter is limited to 2 emitters and only 80 pulses, but we are waiting for the C2 plus catheter that hopefully will be soon releases, increasing the number of pulses to 120, and I think this will be a welcome addition, especially for lesions such as this one with very long calcified segments, in which we had eventually to use 2 different balloons, 80 years old men with heart failure, but normal creatinine. You see these calcified plaque both in the distal left main and in the mid LAD at the bifurcation of this large diagonal branch. You see that the circ is limited to a quite unimportant vessel with a vein graft present of with an open revascularization mode for the marginal branch. You see that you can quite often insert lithotripsy balloon in the studies that I'm going to mention in a second. Around 40% of the cases we needed a 1.5 or 2 millimeter balloon to insert the lithotripsy device, but in this case it was not needed. And you see that when you expand it to 2 atmospheres, you have complete indentation in the area with more severe calcification, enough to activate, to reduce this phenomenon more and more and achieve full expansion after, in this case, 3 series of expansion. But of course you tend to complete all the 80s that we did with this trio lithotripsy balloon across this segment, and at this point we could pass an intravascular ultrasound catheter, and you understand that this was a truly 270-degree arc of calcium, quite irregular and over a long segment involving also, as you see, the distal left main. So we completed the work stenting the mid-LAD and the proximal LAD after having pre-dilated the ostium of the diagonal branch with the drug-eluting balloon, and we did a final kissing balloon dilatation for mid-LAD and diagonal. We performed a 3.5 millimeter shock wave on the left main and proximal LAD, again, incomplete expansion that at the end of the series of shock waves becomes a fully expanded balloon, allowing implantation of these two stents, the largest 4.22 millimeter, and final expansion with a generous 6 millimeter balloon for the left main proper, with full expansion with high pressure balloon over the entire segment. We normally don't go to crazy pressure. 24, 26 maximum is what we use. We don't need, once lithotripsy is done, super high pressure balloons. And this is the result that we obtain in various views with this excellent expansion. In this case, we limited ourselves to a kissing balloon dilatation for the proximal LAD and circumflex branch, where there is excellent flow. And this is the way it looks in the various segments that you remember, where most of the calcium were present, with good expansion also in the area with more than 270 degrees. So we learned about this technology quite some time ago. I was not the first Azim to start. It was in Australia and New Zealand, the first 12 cases, but then we followed in Europe rather quickly. And in fact, I was the main enroller in the Disrupt CAD1. And these two trials, of which I was honored to be PI, CAD1 and CAD2 trials Disrupt, also told us what is the operative mechanism of this technology. In more than half of cases, we could see visible ruptures of the calcium, allowing further expansion of the lesion with stents. And this is an example. So initially, the lesion had not to be longer than 32 millimeters, it had to be covered by a single stent, but you see, you can act between these two diagonal branches surgically without disrupting the vessel more proximally or distal, like you often have to do when you use super high pressure balloons. Putting together the 4 disrupt registries that were FDA quality, so with excellent complete monitoring, follow-up, and independent analysis and case adjudication, you see that these 628 patients reported by Kyriakis and co-workers, 1/4 of them with renal insufficiency, 40% with diabetes mellitus, severe calcification confirmed by a core lab in 97% of cases, so a rail of calcium, facing calcium in one view, angiographically demonstrated, 24 minimal average length of calcium, but the entire calcified length was 41 millimeters, so not the easiest lesions. Also, obviously, this is a de novo registry, left main was excluded, CTO was excluded, and so forth. We achieved an expansion with lithotripsy balloon only that is unthinkable for such a calcified segment. We managed to reduce the diameter stenosis from 67% to 34%, and this paved the way to a full expansion after stenting, 11.9% residual after stent implantation. And as you can see, success was obtained in more than 90% of the cases, is not 100%, because we consider presence of MACE, also minimal CK leak, which was present in around 7% of cases. But what we consider clinically relevant complications are in fact very rare. Flow limiting dissection, perforation, abrupt closures, low flow, no reflow are never or hardly ever developing after lithotripsy, are only present after stent implantation in a truly small minority of cases. Sorry, I feel there is a bit of interference. I don't know from what.
Everybody's muted on here. I'm not sure why, Carlos. Sorry about that.
All right. Excellent. Better now, isn't it?
Okay, good.
So I just wanted to tell you some more messages that this trial has taught us. Visible calcium fractures are more frequent when you need them, when the lesions are more severe and concentric, but are visible also for eccentric lesions, irrespective of presence or absence of visible fractures. Expansion for the different levels of arc of calcium tends to be equally good. And in my view, this means that not necessarily we need to see these small fractures to accept the result after lithotripsy. Once we see that the balloon is open at 4 to 6 atmospheres, that's good enough to implant our stent and achieve this complete expansion. We have confirmation from more high-resolution techniques, such as micro-CT, that invisible fractures to even a high-resolution technique like OCT are present or might be covered, like in this case, by thrombus in this nodule, but are present and visible when you use a technique like CT. Eccentric and concentric calcium, of course, concentric is what you really need when you really need this technique, but also for eccentric lesion, you achieve equal expansion. So we learned after a few years from these trials that this technology has advantages compared with other ablative techniques, since it can be used easily and safely in in-stent restenosis, or if you have immediately after deployment under expansion of a stent, you can leave a wire in place, will not be cut like with rotational orbital atherectomy, can be used in deep calcium, can be used in very large vessels, all advantages that not always are present unless you have a favorable wire bias, for instance, with the rotational atherectomy. We now have more information on indication that were not in the initial trial, for instance, calcified lemon stenosis, IBUS in under-expanded stent, in CTO, in vein graft, in ST elevation myocardial infarction. We contributed to the literature reporting the use of peripheral balloons. Now we have 8mm balloons that can be used to facilitate tracking of the delivery system of TAVI or Impella in very calcified iliac arteries. And publication is slowly increasing in this field, and we hope to contribute in the future with this large registry. We just started with around 100 cases in this 2,000 patient trial that we hope to complete in 1.5 years. But we have already some result long-term, like in this multi-center registry of 273 lesions, mainly radial approach, including stent restenosis, de novo, left main, long lesions. As you can see, at an average follow-up of 222 days for the blue lines and 687 for the orange lines, you have percentages of event that are, most of them, single digits, very different from what we saw from the large reported series in calcified moderate to severe lesion treated, even with second generation drug-eluting stent in these 30,000 patients that I showed at the very beginning. Look at this case. I will not go through the number. It's enough to look this image. You have a super thick 0.9mm minimal thickness of this calcified plate. You inflate a 4mm lithotripsy balloon. You have this 3 large cuts, and then the vessel is nicely open and can be fully expanded with the residual area stenosis of, as you can see, around 10%. You need to use it properly to select a balloon large enough to have the size roughly of the reference area, to prepare the balloon well, because presence of air can reduce the impact of the energy on the vessel wall. You don't need high pressure. Going to higher pressure can be helpful only if your balloon is somewhat under, the choice is suboptimal in terms of size. I tend, especially at the first inflation, not to go to 4 to 6, because I want to reduce to a minimum the risk of rupture of the balloon. I tend to maintain 2-3 times the balloon at the same spot, because the rupture is not due to the energy of the shock wave, it's due to the balloon friction against the calcium fracture created by the lithotripsy. So you have to wait that the balloon is fully depleted and move it very gently across the calcified plate. Use it all the energy, all the times. And now that you have 120, that's best. Let me finish very quickly to tell you that next week we will have in New York a large meeting, the largest in the world, in fact, on CTO treatment. And as you know, in CTO, presence of calcium is not 30%, is 70-80%. And this is located mainly either at the proximal cap or within the CTO body, and is the main enemy, is one of the main predictors of failure of treatment. This is a case that shows an impenetrable cap. Of course, you have ways of so-called move the base to enter into the occluded segment, but will be much better if you have a technology such as lithotripsy, where inflating a balloon in this diagonal branch in close proximity of the proximal calcified plaque, you can break the calcium well enough to then penetrate with conventional Gaia 2 wires and complete the work anterogradally. The other advantage that you expect, mainly in the body of the CTO, is when you enter with your wire subintimal, and this is frequently the case. That means all your calcium is opposite to the wire. Instead of doing things like inflation of a balloon immediately against the adventitia at high pressure, achieving a result like this. This is the true lumen. You are expanding the adventitia and creating a partial, fortunately contained rupture, as you can see, not an ideal technique in terms of presence, formation of long-term pseudoaneurysm, and so forth. You can use lithotripsy at 4 atmospheres and obtain a sufficient rupture of calcium to expand lesion where they tried unsuccessfully different technologies such as cutting balloon or high pressure balloons. Let me show you a final case of an occluded right coronary artery where I was lucky changing progressively more aggressive wires to reach the distal end of the occlusion, and to confirm with intravascular imaging after gentle predilatation that I was within the body of the occlusion true to true, checking that there is a 360-degree arc of calcium in the body of the occlusion. I decided, instead of use super high pressure, to use lithotripsy, and this is the result obtained after 80 erogation of a lithotripsy balloon. My conclusion is that calcified lesions are frequent, associated with a worse clinical outcome, with more frequent complication also during and immediately after the procedure. When there is calcium expected, now many of our patients already come with CT coronary angiogram before, so we can somehow predict, or angiography also in many instances can give you an idea of the presence of calcium. Use liberally pre-procedural imaging. No issue if you just use a 2-millimeter balloon to get your intravascular ultrasound imaging across. Still, this does not prevent you from the use of all the other dedicated calcium modifying technologies, including rotational or orbital atherectomy and lithotripsy. Rotational atherectomy, I believe, is a technique which is going to stay with us because uncrossable lesion will always require the application of these technologies to go through with our shockwave balloons, and it's probably worthwhile to use it for long severe stenosis. At that point, you may see what happens with a high-pressure balloon. If it expands, fine. Otherwise, there is nothing against using rotatripsy, combining it with intravascular lithotripsy. But don't go to very large burr that gives no reflow, slow flow. You don't need it when there is incredibly difficult tortuous anatomies, small distal vessel in female patient, more prone to complication. Intravascular lithotripsy has gained wide application because it's easy, because of course will still require careful planning and choice of balloon big enough with enough number of pulses delivered per segment. But if you follow these simple rules, stent expansion, final expansion with balloon dilatation, and final control with intravascular image, will deliver in almost all cases a final good expansion in these very complex, difficult to treat lesions. Thank you.
Carlo, thank you so much. There was a phenomenal talk on calcium and how IVL fits into it. I have lots of questions, but before me, I think it's more important we get some of the team to answer, if you can, to answer their questions. I'm going to start with Katie. Katie, I'm sorry to arrest you while you're on your way, but but I'm sure you have some questions for Carlo.
That's totally fine. Yeah, that was a great talk. I have two questions, but I'll ask the first one and then other people can ask questions and I'll ask it later if there's time. But you really nicely pointed out how important intravascular imaging is to make sure that you're both identifying the calcium and modifying it correctly. And I think all of us who do this work recognize how important intravascular imaging is. But yet the rates of its use in the US, and I believe it's similar in Europe, are still really low, like less than 10%. One, do you think that the low rates of calcium modification techniques correlate with the low rates of intravascular imaging? They're just not being identified and thus aren't being modified. And two, like, how do you think we fix that? How do we convince people how important intravascular imaging is, both for stent sizing and for calcium modification, particularly when, for example, in the US, in the stable ischemic heart disease guidelines, imaging still only has like a 2-way recommendation?
But I think you already gave the answer. Convincing data that make imaging +1 in guidelines. Let's be honest, we do have some of these trials, but the largest 1,000 patient trial is a Chinese multi-center trial that maybe not everybody fully buys. There are a couple of other trials ongoing, even in situation like left main, in which there is, in my view, overwhelming evidence that intravascular ultrasound is needed to understand what technique is better, one stent, two stents, how to expand, vessel size is very unpredictable. Still, the use is probably 30 to 40%, at least in Europe. I think there is a slow increase. I mean, I started in England in 2003, and I'm sure that Azim remembers that at the time, they consider me an eccentric Southern European using it in 50% of cases, while they were using maybe in 5% only when they wanted to show off. But right now it's 23% in England, which is a significant improvement. And there are centers, New York, St. Francis, Columbia, your center, where I'm sure is used in majority of cases. So it's just a matter of education, because it's not enough to use imaging. You have also to understand what it means and how to react, and trials good enough and convincing enough to bring it up in guidelines.
Great, thank you very much.
So, Carlo, just so you know, at Monty, our intracoronary imaging usage is 90%. So yeah, we take a lot of pride in the fact that our attendings, our entire team uses it a lot. Before I go to some of the fellows, Juan, any comments?
No, I was going to, the only comment is, how to fix it is a combination of economics, training, physicians, and making it work in terms of time, because it is time education. Look, I mean, the biggest, thing that goes against imaging is that majority of operators are really scared of using it because they don't know how to interpret.
They're not interpreting.
So that's why where you start talking about AI and automatic interpretation of images and actually helping people to self-assess what they're seeing could potentially be very helpful and increase utility of the use of
and I think at both CTO next week and at TCT, there's a lot of, it's very imaging heavy, right? Just about all the cases will be done with imaging. I mean, I think there's probably also opportunities in part of the training village at TCT for us to work with, the imaging companies to do more training, because I think training is the part that's lacking. I mean, like in a center like ours, where 90% of PCIs have an imaging catheter open, it doesn't feel like it adds to the time much anymore, because the catheter has already been opened before I walk into the room. It's already prepped. And so, we just do it, right? But it's how you interpret the result of it that's important. But let's get a little bit back to calcium. Before I pass you on to some of the fellows, they've all got some great questions. One of our other attendings, Asma, asked, underexpanded stents, when the stent's already been put in and it's clearly underexpanded and it's because of calcium, she's asked about what happens if you have an acutely underexpanded stent and using shockwave. Because there've been some reports about you damage the polymer, you do this, whatever, but I always think isn't it worse to have an underexpanded stent? Any thoughts? Your thoughts about a freshly implanted stent and that's underexpanded, Carlo?
Well, I mean, first of all, there are instances where you have underexpanded stents, also if you are a reasonably experienced interventionist. For instance, acute coronary syndrome in the middle of the night, the way I tend to go with a small balloon, I restore some flow. I tend not to go to the one-to-one balloon for pre-dilatation. I implant my stent with the idea that this may also reduce the amount of thrombus showering down the vessel. Sometimes I'm punished because there is an area of incomplete expansion and I missed, angiography is not perfect for that, an area of a segment with the napkin rings. So in the past, it was super high pressure with small balloons. Often it worked. Sometimes induced vessel perforation. Now we have a safe technology. Let's use it. We don't have large enough trials to tell us that the small damage that is present in the cover, in the lining where the drug is present and has to be eluted against the vessel, may make a difference in the long run. It's very unlikely, in my view, However, obviously, you would dilate properly and use lithotripsy before in an ideal world. But occasionally, you may do that. You may use a stent before. I don't think is a particularly bad issue. You know, something that I am also considering is sometimes when you have left main disease and even short repeated series of inflation may induce hemodynamic compromise. If you, for some reason, you can't insert an impeller, for instance, you may implant the stent knowing that will not be perfectly expanded and do your lithotripsy later, because then with the stent, you will rapidly, after deflation, achieve a good flow. So that's another way you can consider use of lithotripsy after stent implantation that I consider again, not ideal, but still working and a good option.
Thanks, Carlo. If you have time, we're going to move on to some of the questions from the fellows because they always have great questions. Guillem, you start first. Why don't you had a couple of questions. Let's maybe keep one or two so we give other people a chance, yeah?
Thank you. Well, thank you for your lectures. We learn a lot. Well, thank you. My first question, so if I choose one, it's what is your decision tree that leads you to combine the two techniques, intravascular lithotripsy and rotablator, and which one you will use first?
Right. Well, I will normally use first rotational atherectomy because that's for uncrossable lesions. So it's a bit unusual that I have a case like the one I showed when lithotripsy balloon went broken after in the first series of inflation, so didn't do much on the calcium, and I felt that modifying it with rotational atherectomy was a better option. I will use rotational atherectomy when I have a fairly long segment, because I think that this will also help me to spare, inverted commas, the number of lithotripsy balloon that I need to use, and to make sure that I can insert it more easily with less risk of rupturing them or breaking them.
Thank you.
Andrea?
Yes, Professor Di Mario, congratulations for this great lecture. I have just one question. Based on your experience and the current technology on intravascular lithotripsy, how do you see the future of this field in terms of devices and their use? What do we need at the moment?
Well, I think that you need to use it when it's appropriate. And that means that you select your cases based on intravascular imaging. That means you use in some cases when angiography does not show calcium, but there is severe calcification, and you maybe not avoid it when because of very thin calcium, because of a not too long calcified segment, a high pressure balloon is good enough. At the end of the day, this is an expensive technology, and you know, put your money where the value is, and that's the most severe, mainly 360-degree calcifications.
Katie, I saw you had another question. Please go ahead. You're on mute.
Yeah, I was just curious, how do you size the IVL balloons in the subintimal space? Because, you know, with normal NCs, as you noted in your slides, we get kind of nervous about using big balloons at high pressure out of fear of causing a perforation, since we're not truly in the vessel itself. So how do you size that? Is it based on the reference vessel diameter? Do you have like a maximum balloon that you ever pick, like a 3.0 or a 3.5?
Yeah, thank you for your question, Kathy. Well, I think I will size on the distal reference, which most of the times is anyway underfilled. So I'm aware that I will somehow use a smaller balloon than probably required, but we are really speaking of a very new application. You know, there are so far 30, 40 cases published and maybe a few hundreds done with this technology, despite calcium is present in the vast majority of CTOs. I think we will learn more and more by using and by reporting results what's the best way. And in my view, the main advantage is you don't need high pressure. You know, of course, one of the determinants of vessel perforation is size, but the other is pressure. If you go at 4 atmospheres, even a very large balloon is very unlikely to break the artery.
So can I ask another question about that, Carlo? Because it's something, you know, I have this discussion with the fellows all the time, because shockwave, when they come and they do in-service training and they keep saying, oh, you know, you have to size 1-to-1. And I go, well, hang on, you know, in some, even though, you know, where the ring of calcium is, or where the severely calcified area, you may not tolerate a large size balloon. And it's apposition that's more important than being 1-to-1. Just thinking of this, we started to have balloon, shockwave, and then you went to a bigger balloon. So, I mean, how do you think about sizing when it comes to shockwave? Does it always have to be 1-to-1?
Well, I mean, of course, as long as there is good apposition, you will do something good to the calcified plaque in the wall. I would say the maximum effect and the most efficient use will be having a balloon of the reference vessel, matching the reference vessel. And you can do it because, you know, unlike for cutting balloon or other aggressive balloons, super high pressure balloons, where it's better to undersize because you have to inflate them to 18, 20 atmospheres, the cutting, and maybe 40, 45, the super high pressure balloons. Here, you are inflating at 4 atmospheres. So you are not really damaging. You're not creating large distal sections.
So it's just got approved, the OPN balloons here in the US. I just literally ordered some yesterday for our team. So they're going to arrive next week. I used them a few years ago, and when I used them, we weren't using a lot of shockwave. So maybe to understand in your practice, now that you've had all of these devices for a few years, you have all the specialty balloons, you have OPN, you have shockwave, and now also you have CSI in Italy, which you never had before. Okay, what role it's a few questions in the chat. What role do you see for OPN in your practice? And then second question, what role do you see for CSI in your practice?
Well, I mean, I think the role of OPN has been reduced by the development of especially lithotripsy technology. However, very short sort of napkins ring with an undersized balloon at very high pressure in a stent that can be an alternative. There are balloons that anyway are high pressure balloon, truly non-compliant. You know, a non-compliant balloon of a normal brand at 30 atmospheres is at least 15% bigger. Those balloons are almost say nominal size at 28-30 atmospheres. So there is an improvement in technology that you can just use, and is a slightly thicker wall than a normal balloon, so maybe it's slightly less deliverable, but most of the times they go, especially before being inflated, they are quite sleek enough to go in most cases. So I think you will have favorable experience, also not as wide application as we had 15 years ago when there was nothing else. Orbital atherectomy, well, you are the master. Unfortunately, in Europe, the experience is limited. In my region in particular, I have to order on a specific case. So you can imagine that they didn't do many. I mainly do use it for nodular calcium.
Right, okay. Asma, you had a question?
Yes. Hi, Zim. Hi, Dr. DiMario.
Carlo, Asma is also one of our attendings and a big part of our team. She does endovascular as well as coronaries.
Hi, Dr. DiMario. That was a great talk. Thank you. I do have a question. So how many percentage of your rotablation cases have been replaced by IVL at the moment? And also, how do we in US reconcile with the fact that IVL is still not a billable code. And sometimes we have to open, a rotablation, a rota, just so that we can absorb the cost of IVL into it, because we still don't have a billable code for it, and it tends to be expensive technology. Could you comment on that?
Yeah, well, Europe is worse because we have no special reimbursement for rotational atherectomy as well. So, in fact, these cases, the only way to cover the cost is try to limit their use to the most complex lesions. I think that the only way is to convince the payer that there is an advantage in using a device that seems to improve outcome in terms of better expansion and reduce percentage of procedural complication and late events, thrombosis and restenosis. How to do that? That's a big question, because as you know, FDA that normally so open and forcing companies to perform randomized trials, in this case felt that there was not a good enough standard technology against which lithotripsy had to be compared, and allowed the use of this larger registry that I think delivers very convincing data in terms of safety and efficacy, but not comparative data. So it's difficult then to have this climbing in the guidelines to class 1.
Carlo, there was a question on the chat. When we talk about shockwave and we talk about the pressure of these shockwaves, we talk about up to 50 atmospheres these shockwaves can have. Does that pressure drop off the further away you go from the emitter? So if it's a larger vessel of very thick calcium or deeper calcium?
Yeah, I think so. I mean,
no real data though, right? We don't really know.
Well, I don't think that you can know whether it's exponentially or linear, the decay, but I think everybody has experience of some super thick nodule of calcium where you can apply all the lithotripsy you want, but still remains indented.
Carlo, do you have time for a couple of more questions from the fellows?
Yeah, welcome.
So short questions, team. Julio?
Thank you, Dr. Di Mario, for this wonderful talk. I have two questions very quickly. One of them is, what about the risk of embolization? Is there any difference between the types of calcification and central or concentric? And the second question is there any difference in the outcomes between women and men with the treatment of IBR?
Yeah, well, thank you for both questions. I mean, first of all, embolization, we don't see slow flow, no reflow, because there is no real embolization. It's not a mechanism similar to fragmentation of plaque, like rotational atherectomy, where if you create a large number of plaque debris, of course you will plug the capillary tree. Here the calcium remains in the wall covered by line of endothelium, so it's very unlikely that you create any embolization. The second question, there is a published paper on the around 200 patients, 178 if I remember well, women in DISRUPT compared with men, and the results are very similar in terms of expansion, which I think is good because, of course, arteries of women are smaller, difficult to quantify tortuosity, but they are certainly more tortuous. And there are previous papers showing that application of rotational atherectomy in women is fraught with a higher percentage of periprocedural complication, especially perforation, while this doesn't seem to be the case for lithotripsy.
Right. Matteo?
Hi, good morning, Prof. Di Mario. Thank you so much for this talk. It was very, very insightful. I have a question about the use of shockwave in eccentric less than 180 degrees and then nodular calcium. You showed some data that there was good stent expansion regardless. I was curious, with just 2 transducers, maybe like what is your approach? Do you change the way you use a shockwave balloon than would you if it was just completely concentric calcium? Thank you.
But you have noticed that there are more often no visible fractures when you treat eccentric lesion, and same for nodular calcium. Having said that, expansion seems to be similar. I mean, first of all, I think that I tend to use more pulses per segment. So to stick to full series of pulses, for instance, across the nodule. Also, the results were quite good in the Disrupt trial. I would say true super severe nodular calcification were probably not very frequent in this particular trial, and still we have to learn quite a lot. And some of our results, I don't think are perfect, purely based on lithotripsy. I think that's a field where combination, especially orbital, which has the advantage that can use the wire bias in 2 directions. So if one of the 2 will be good, is better.
Samina, Faraj, last couple of questions, very short, please. Samina first.
Thank you so much for the great talk. My question was related also to calcified nodules. I was thinking, when you said like you move the balloon, you do more impulse, do you also move it slightly or rotate it, because there are just 2 emitters? And my second question is about what are your thoughts on using cutting balloon at high pressure in this setting?
Well, thank you. Yeah, I tend not to move for the first 2-3 series of erogation. That's the way we did in Disrupt. So if you want to match the good result of the registry, I think that you should also follow a little bit this approach. Yeah, slight changes in position afterwards, I think, are logical. But again, I see people moving the balloon all the time. Just find with a touch of contrast your ideal position across the most calcified segment and try to have enough pulses erogated to see full expansion. Once you have done that, then you can complete the work in nearby segments. Your second question was about nodules. Well, I don't think I have much to add to what I just said. I think that's still a very hard beast to deal with, and probably synergy of different devices may help.
Faraj, quick question.
Thank you very much, Professor Di Mario, on this elegant summary. A very quick question. Do you always deliver the 80 pulses? And when would you recommend use intracoronary imaging to assess luminal gain before stenting?
You mean after the IVL?
After IVL, any utility to assess luminal gain before stenting? When would you do that?
You routinely do imaging after you do your IVL? Maybe start with that one,
so we did use routine imaging, often OCT, in the trial. And I think that was a way for us to learn how it works. Since now we know that presence or absence of visible fractures is not predictive of outcome, I don't think there is much clinical justification for that. Having said that, first of all, sometimes you can do pre-interventional imaging because the intravascular ultrasound catheter doesn't cross. It's too calcified at the start. So you will use it as an assessment before stenting to decide stent lengths, stent diameters. So you will need it anyway. Yeah, I think that's the main answer. Nowadays, I tend maybe more often to use ultrasound than OCT because, of course, they are beautiful images, but I don't think adds much to physically see one rupture more or one rupture less.
Absolutely.
Thank you.
Last question from the chat, maybe, Carlo, before we let you go. There were some reports in the literature of capture from when you're doing myocardial pacing capture, when you're doing shockwave, and maybe 1 or 2 reports of R&T phenomenon. I've not been very concerned about it. I mean, we've done years since it got released, probably about 150, 200 cases of shockwave already. We've not had 1 case. Have you had something you're concerned about?
Well, I think if you have 15% ejection fraction, having, direct activation of the ventricle, maybe it's not so good, but then probably you will have an impeller already, isn't it?
Exactly. So you're not too much of a concern.
No.
Carlo,
I never see any arrhythmia, if this is the question.
Neither have we.
VT or VF, never seen. Thank
Carlo, veramente grazie mille. Thanks to the fellows. Katie, thank you so much for joining and helping to with the great questions and moderating. Stay well and enjoy CTO Summit, the 2 of you.
See you next week. Thank you.